Good morning, people. I don't know if you noticed, but as the semester's gone on, I'm dressing less and less professionally. This is science related. It's a brain, but this isn't a brain class. It's a hard class. But anyway, hard to roll out of bed at 9:30 to make this class, but I did it. I did it. Um, I just uploaded two things to your Moodle site. One is today's PowerPoint on heart failure, and the other is I asked Perky, the guy who gave us a talk on Tuesday. I asked him some questions, and he came back with this huge, beautiful spiel on pharmacotherapy of congestive heart failure. So I put it into a Word file and uploaded it there for you to look at. And maybe we'll read it at the end of this class if we've got time. But anyway, what do we got? 1, 2, 3, 4, 5, 6, 7. Better than usual. I don't know where these other people are. These are the losers. So if you're watching this Zoom recording afterward, you're losers. Just kidding. Just kidding. You know me. It's kind of hard to maintain decorum here when basically I'm in an empty room by myself, and I can do whatever I want usually when I'm in an empty room by myself. But today we've got people here. Okay, hang on. Heart failure. So today we're going to talk about heart failure. And as we learned on Tuesday, there are two different kinds of heart failure, systolic and diastolic. But to start out, what are the symptoms of heart failure? So the number one thing is, the basic dysfunction is that the heart isn't able to pump blood as well as it used to. So it's not able to keep up with the metabolic demands of the body. So that's the basic problem. But then there's the decompensation of the body, which is basically, when your cardiac output decreases, your body responds by activating the sympathetic nervous system, and then that increases your cardiac output. And that works for the short term. When you're laying down, suddenly stand up and everything changes and your sympathetic nervous system makes it work again. But when you're chronically stimulating through the sympathetic nervous system, trying to get more and more work out of that heart, the heart is eventually just not going to be able to perform. Like Perky says in his thing that I uploaded, basically it's like you're hitting this horse to try and make it run faster, but eventually the horse is just going to die. So that's what's happening here with the sympathetic nervous system. But these symptoms that we see, I'll talk about them again later, are all because of a combination, of the decrease in cardiac output and the sympathetic nervous system's response to the decrease in cardiac output. So what we see is shortness of breath, okay, fatigue and weakness, swelling in the ankles and feet, rapid or irregular heartbeat, increased need to urinate at night, swelling of the abdomen, rapid weight gain from fluid retention, reduced ability to exercise, persistent cough or wheezing, and sudden severe shortness of breath and coughing up pink foamy mucus. Never cough up pink foamy mucus. It's not good. All symptoms are due to your decrease in cardiac output. So here are two different types. One is diastolic dysfunction, and Dr. Gogo talked about this on Tuesday. Basically, this is heart failure with preserved ejection fraction. So we'll talk about ejection fraction later a little bit. Basically, you've got a hypertrophic heart. So the heart has been under a lot of stress for a long period of time, and when you stress a muscle, it gets bigger, right? So here, the ventricular muscle is a lot bigger than it's supposed to be, and as a result, it can't relax as well. So because it can't relax, it can't really fill properly. So you're getting a decreased cardiac output, but your ejection fraction is the same because you still have a strong muscle. It's just that it's not filled as much before it starts to contract. So you're getting less blood out. The percentage of the blood in the ventricle coming out is the same as it used to be because you're still contracting really strong. but the amount coming out is less. So that's heart failure with diastolic dysfunction. And again, this is due to ventricular hypertrophy. Systolic dysfunction then is when the heart just can't, the muscle can't contract as strong. So the ventricle's unable to contract properly to empty it. And now your ejection fraction is going down because, you know, the ventricle fills and you can't really contract. So the amount that's in the ventricle that's coming out is decreased. And this is what we call congestive heart failure. Congestive because you get an increase in the diastolic volume. Okay, your body's trying to get more blood out to itself, so it's increasing venous return, but you can't contract as strong, so you get an increase in systolic volume too, so the heart just gets bigger and bigger. And so this is what we call congestive heart failure. Okay, so now to go over each of them in a little more detail. Hypertrophy is caused by overworking the heart. So we're talking about the preserved ejection fraction, diastolic dysfunction. So you're overworking the heart here with either chronic hypertension, right? And this is really high blood pressure over a long period of time. And also valve stenosis or insufficiency. So Dr. Gogo talked about this on Monday, where that aortic valve is supposed to open fully during systole and close fully during diastole. So that's normal valve function. So what happens is sometimes that valve gets stenotic, which means it's stiff, and so it doesn't open all the way. So just like he was talking about a garden hose, instead of opening all the way, you're putting your finger in front of that hose, and so there's a lot more pressure building up behind it. So your blood pressure may be, you know, still in the normal range, 120 over 80 or 130 over 80, but the pressure in the ventricle is a lot higher because the ventricle has to contract really strong to get it through that little tiny hole. So he was saying the pressure in the ventricle might be as high as 300 millimeters of mercury. So the heart's working really, really hard, and so it starts to hypertrophy. It needs to work harder. Valve insufficiency as well. Insufficiency is when it doesn't close all the way. So it opens fully, but it doesn't close all the way. So you get regurgitation, it's called. That, you know, during systole, the pressure is higher in the ventricle, so blood goes out. And then during diastole, as the ventricle is relaxing, the pressure is higher in the aorta, and the valve doesn't close, so blood comes back into the ventricle. That's regurgitation. And so now the heart has to pump harder to keep your cardiac output up because it doesn't, it's filling with blood that already should be out already. So it's even if your stroke volume is normal, your stroke volume is really not normal, right? Because that volume went out, but then it came back in. Okay, this increases the work that the ventricle has to do and results in hypertrophy. Valve problems. Okay, so I just said this, but here we are again. Aortic stenosis is when the aortic valve doesn't fully open, and that increases your afterload. Okay, and the afterload, we always say afterload is your blood pressure, but in this case, the afterload becomes that valve itself because the ventricle doesn't see the blood pressure of the body anymore. It just sees what pressure it needs to get up to get through that little valve. Oh, and here's my spelling error here. Let me fix that. As long as we're here. I'm like I don't know how about you guys in typing, but I constantly transpose letters when I type. But anyway, that's not your problem. And then, so that's aortic stenosis. And then insufficiency, I should have written here as well, is when that valve doesn't close all the way. Here's your stenosis. Okay, this is normal, closed, open, closed, open, closed, open, closed, open. And here's your stenotic valve, diseased valve. So it's closed, but it doesn't really open all that much. So you have to squirt blood out that little hole. And that increases your heart load, your afterload. Insufficiency then is again regurgitation. Here's your aortic valve. Heart's relaxing, and while blood is supposed to be coming in through the mitral valve, it's, oh shoot. Sorry. Supposed to be coming in through the, oh, come on, man. I've got this sensitive touchpad here. It's just bothering me. Okay, so while it's supposed to be coming in through the mitral valve, it should not be coming back in through the aortic valve. And so you're getting mixing of blood that should be just going in one direction. Also, there's mitral valve insufficiency as well. And that's when the heart contracts and blood regurgitates back up into the aorta. And that's bad. That creates pulmonary hypertension, and you get edema in your heart because pressure's coming back into your heart. I'm sorry, pulmonary edema because pressure's coming back into the lungs in the respiratory circulation. Blood moves back into the heart during diastole. Heart needs to work more to meet the needs of the body. Okay, so both times in both conditions, your heart has to contract stronger, and so you end up hypertrophying. Okay, systolic dysfunction. So this is heart failure with reduced ejection fraction. So we've got a decreased ejection fraction, blood accumulates in the heart, and the heart enlarges. So here's your normal size heart, and here you can see how much bigger this heart is, and the walls of the heart get thinner as well. Okay, so here's it contracted. This is contracted, but the blood is still in the heart there. So ejection fraction. I think down below I talk more about ejection fraction, but I'll just say it now. I just got a chat. How do drugs fix this when the valves are not functioning properly? Yeah, drugs aren't going to help you with the valve problem at all. Basically, like Dr. Gogo said on Tuesday, you need to replace that valve. And they can do that through a catheter now. It would be a cracked chest kind of operation, but now they can run a catheter up from your leg and break open that old valve and put a new valve in. But yeah, drugs aren't going to help you with that. They can decrease the workload of the heart. We'll talk about that later, but it's not going to fix the problem. It's only going to kind of make your heart work a little easier. Okay, systolic dysfunction. What else did I want to say here? Oh, ejection fraction. So I think I talk about this in a later thing, but basically ejection fraction is stroke volume over end diastolic volume. So how much of the blood in the heart actually gets out. And as the heart weakens, your stroke volume decreases and your end diastolic volume increases. So ejection fraction goes down. What causes heart failure? Genetic defect, especially if heart failure occurs in a young person, it's because there's something wrong with their heart. They could have any number of proteins mutated that cause a weak heart contraction. Viral or bacterial infection, believe it or not, bad dental care can cause cardiac heart failure, because a lot of the bacteria in your mouth, if it goes septic, it can go to your heart and then cause an infection there. So that's another cause. And again, these are mostly in younger people. This is why they get heart failure. Chronic hypertension, right? Like we talked about before, the silent killer. You don't even know your blood pressure is high, but your heart's overworking and your body's compensating for that up to a point, and then it starts to decompensate. Coronary artery disease. So you're decreasing blood flow to the heart muscle, heart cells start to die, they get replaced by fibrotic tissue, and then your heart just doesn't have the ability to contract as strong because it's got fewer cells. And in a larger sense, myocardial infarction does that too. If you're talking about like a massive heart attack, well, then you just die. But a lot of times people will take small heart attacks, losing little bits of muscle here and there, and that weakens the ventricle because you've got less muscle to contract. Okay, compensation versus decompensation. We've talked about this. I've been talking about this a bit today without explaining it, so this is where I explain that. So normally, if you've got a slight decrease in cardiac output, we've been talking about this already, activate your sympathetic nervous system. And then that, it stimulates your heart to contract stronger, and then your cardiac output comes back up and you're fine. In systolic failure, the ventricular muscle is weak. So when the sympathetic nervous system kicks in, you can't get a stronger contraction. So it starts to do all the other things it does. So it increases heart rate, increases resistance to get your blood pressure back up, and increases venous return. And all of this just makes it harder for the heart to work because it's got a higher preload and a higher afterload, and it's already not able to do its work, and now you've given it more work to do. So normally your cardiac output decreases, sympathetic nervous system kicks in, that increases contractility and heart rate, and that increases your cardiac output. Everything's good. In decompensation then, cardiac output goes down, sympathetic nervous system kicks in, can't really get a whole lot more contractility out of that heart because the muscle is weak. But the heart rate does go up. Does your cardiac output change? A little bit, not a lot. And so you do more sympathetic nervous system stimulation, venous return increases, that's your preload, your total peripheral resistance increases, that's your afterload, so you get increased preload and afterload. Doesn't really help your contractility out that much because the basic problem is your heart is weak. And so your stroke volume decreases and your systolic volume increases and the heart enlarges. And then the larger it gets, the less strength it has to actually contract, and so you decrease your cardiac output. Here is that Frank-Starling relationship we talked about way back. So this is normal under rest conditions. As you increase venous return, you increase, so this is venous return, right? And oh shoot, I've clicked on it again. This is your venous return. Oh, I'm sorry. Venous return is here. So the more venous return, the more stretch in the muscle. And the more you stretch the muscle, the stronger the contraction is. So here's normal. Increasing venous return increases the active contraction of the heart. And so the heart contracts stronger. And then if you're exercising, you increase sympathetic nervous system, and that inotropy increases because of cyclic AMP in the ventricular cells. So you've got a better ability to contract anyway. So then as you increase venous return, you get an even better cardiac output. When you're in heart failure, stretching will increase your cardiac output a little bit, but not nearly as much as it's supposed to. So the heart starts to enlarge. And as you get towards the end of it, your ability to increase contractility really decreases. So you've got this big balloon of a heart and it really can't contract. Remember, as you stretch too, if you stretch too far in the Starling curve, thin and thick filaments go from maximum overlap to less overlap. So if you look at this curve, because you've stretched out, it's all to the right of your optimal. So this is optimal. And now here you've stretched past optimal overlap of actin and myosin. So you can't increase your contractility because the heart just doesn't have that ability anymore. So basically, when you're looking at this is your contractility curve. Going this way is increasing contractility, going this way is decreasing contractility. So down here, dyspnea and pulmonary edema. Dyspnea is being short of breath. So as you get down towards this area, you end up short of breath. Pulmonary edema over here is when pressure is backing up from the systolic, from the left side of the heart back into the pulmonary circulation. High blood pressure in your pulmonary circulation causes fluid to come out, and you get edema in the heart. In the lungs, and that decreases the ability of your lungs to pull in oxygen. So here's our stroke volume relationship here. Left ventricular pressure here, left ventricular volume here. So this is normal during diastole. The volume's increasing a lot, but the pressure isn't increasing much because the muscle's able to stretch really well. And then the muscle starts to contract and pressure goes up. And then right here, your aortic valve opens and the volume decreases as you eject blood. And then you go into diastole again. So the difference between here and here is stroke volume. Now with your decrease in inotropy and increased venous return, you're starting way up here on the curve already in terms of stretch on that ventricle for the left ventricular volume. And then as it fills, the tension increases dramatically in the ventricle as opposed to normal, because the ventricle's already stretched and you can only stretch it so far. So pressure increases as you try to fill, which means your end diastolic volume isn't as big as it should be. What am I trying to say? The difference between the end systolic volume and the end diastolic volume isn't that great, because when at the end of systole, you start to fill again, but you can't really fill that much because the heart is already stretched. And you can see that here, your end systolic volume is really large compared to normal. And then tension increases, so the difference between end systolic volume and end diastolic volume isn't that much. And then you start to contract. Okay, aortic valve opens, ejection. So your stroke volume now is much smaller than it was, and that's because you're decreasing inotropy. Okay, so I should have put this slide earlier. Ejection fraction then is the amount of blood pumped out of the ventricle. Oh shit, I keep hitting this. The amount of blood pumped out of the ventricle divided by the amount of blood in the ventricle. So this is your end diastolic volume, and this is your stroke volume. So stroke volume divided by end diastolic volume gives you your ejection fraction. Excuse me. And this is kind of a cutesy chart to tell you what's good and what's bad in terms of ejection fraction. So normally your ejection fraction is about 55 to 70, so usually about 60. Higher than that, you've got a good, strong, functioning heart. You start to get lower than that, and you start to get into heart failure. 40%, below 40% is usually kind of the cutoff to the point where you're really in trouble. But this is low functioning, and then this is heart failure down here. Okay, so symptoms. Let's look back at our symptoms, and now that we all know about cardiac output, let's talk about where these symptoms are coming from. So shortness of breath or dyspnea, that's because you've got decrease in cardiac output, which means you need to get more oxygen to your tissues. So usually how you do that is breathe more and move more blood, but you can't really do that. And so you've increased the blood pressure on the systolic side, which is backing up to the pulmonary side. And if you remember when we talked about capillaries, you've got this, balance between blood pressure and plasma oncotic pressure, which is keeping the fluid in the capillaries. In the capillary bed, fluid goes out, but then plasma oncotic pressure pulls it back in. So you've got that balance. And here, blood pressure increases and it throws the balance off. So fluid is more going out. And now you've got fluid in that space between the capillary and the alveoli. And oxygen has to diffuse from the alveoli into the capillary, and oxygen doesn't diffuse that well through water. So you've put water there, and now it's hard to get oxygen into the capillary. So now you've got shortness of breath. You're breathing really fast because that's your body's response to oxygen levels dropping. But it's not necessarily helping at this point. Again, you're decompensating. So bottom line here with shortness of breath really is less the cardiac output than the pulmonary edema, because your blood pressure is increased and you've got fluid in the lungs, and that's inhibiting the ability of oxygen to move into the capillaries. Rapid weight gain from fluid retention. There's a line in this, in a song by Lyle Lovett, talks about temporary weight gain due to excess water retention. It's a really good song, but it's neither here nor there right now. I'm sorry. Okay, edema. So blood pressure, again, same thing, but now we're talking about peripherally, not in the lungs, but in the whole rest of your body. You've got edema because your blood pressure is high and you've lost that balance between your plasma proteins and your blood pressure. So usually you see this in the bottom of your body. You see your ankles. So if you go home for Thanksgiving, which I hope you do, and you see um, your grandparents, if they're, or your great grandparents, hopefully, if they have poor circulation, they call it poor circulation, their ankles are swelled up, and if you push on it, it'll stay in and slowly come back out. So it's not like muscle where it's hard; it's like fluid there, and so that's your fluid retention and edema. Reduced ability to exercise, right? Because your cardiac output is decreased, and they often say this is how people realize they're cardiac out in heart failure, because they're feeling probably a little more fatigued and weak, but they're getting along. I'm getting old. It's just what getting old is. And then they try to increase their exercise suddenly. Like classic example is you're walking to the bus stop and the bus is leaving, so you step it up a bit, take a few quick steps, and then drop, because you don't have that ability to increase your exercise. So that's reduced ability to exercise because you can't increase your cardiac output. A rapid or irregular heartbeat, again, sympathetic nervous system. Can't increase contractility, but it does still increase heart rate. Persistent cough or wheezing, again, pulmonary edema. You got fluid in your lungs try to bring that fluid up, and that's your cough or wheezing. And down here, when it gets really bad, you're actually getting pink foamy mucus out, which means there's actually blood going into your blood cells going into your edema, as well as just water. Increased need to urinate at night. Postural changes, that should be a capital D. Escape. Oops. Oh, Jesus. That's my father. Jesus. My mother was Jesus, Mary and Joseph. Symptoms. Okay. What? Oh, this. Capital D. Okay. Okay. So postural changes. Okay. So when normally, your blood is moving around normally, and and you're getting edema in your ankles and your feet. Maybe you're sitting up and you're getting swelling in your legs. You lay down, now your legs are up, and that fluid can then come back to the heart. So your cardiac output kind of increases a little bit. You get more perfusion of your kidneys, and then you're getting rid of that extra fluid. So at night, because your posture has changed, your kidneys get more perfusion, and so they eliminate more water. So you need to get up and pee a lot at night. Swelling of the abdomen. Okay, again, that's edema. And fatigue and weakness because of your decreased cardiac output. All right, so this is why all that stuff is happening. So what do we do about it? Oh, backing up a bit. We read a paper about this. I read a paper about this. You people just sat there. Way back in probably September, and how chronic sympathetic nervous system stimulation causes problems with your ventricular muscle. One thing is you've got increased beta receptor occupancy, right? You're binding norepinephrine to your receptors on a chronic basis, so you get down regulation of those beta receptors. You also get changes in the G proteins, and everything changes because of that. Remember, your cells are always responding to what is happening to them, so all these things start to change. You've got chronic pKa activation, which means you get hyperphosphorylation of the ryanodine receptor. So this is what that paper was about that we read, which makes your ryanodine receptor leaky. So you get poor relaxation, right? You got calcium there during diastole, so it doesn't contract or relax as quickly or as well. And you're also losing calcium because it's elevated, and your sodium potassium ATP, or no, your sodium calcium exchanger is extruding it, so you're getting less and less calcium in your SR. Okay. Pharmacotherapy. What are we going to do about this? Jesus, Jesus. Again, when it comes to heart failure like this, especially dilated cardiac myopathy, which is your systolic failure, congestive heart failure, all you're doing is kind of like rounding the edges off. You can increase function and keep people going for a while, but it's a progressive disease that's going to get worse and worse and worse. And this is what's going to kill the person probably, unless something else comes up that's worse than this. The only way to solve this is a heart transplant. But they say getting a heart transplant is like winning the lottery. You have to have someone die who has got a heart that is in good shape and also matches your histocompatibility. So the odds of getting a heart transplant is really rare. And also, once you have a heart transplant, I think I'm about 90% sure you no longer have sympathetic nervous system input to it. So your ability to exercise doesn't increase that much. Because nerves don't really regenerate. So when you take the old heart out and put a new heart in, you're not really reconnecting the sympathetic nervous system or the parasympathetic nervous system. So it's still not going to function normally, but it's going to keep you alive, which is a good thing. But anyway, what are we going to do pharmacologically? One thing we want to do is inhibit angiotensin converting enzyme, right? That chronic sympathetic nervous system stimulation of the kidneys. You're probably because cardiac output goes down, the perfusion of the kidneys goes down, and so you get renin release. But also, sympathetic nervous system stimulates renin release. So both of these things are causing renin to go up, which is renin is converting alpha globulin into angiotensin 1. And then in the lungs, angiotensin converting enzyme is converting that into angiotensin 2. Angiotensin 2 is then a direct pressor, right? It's contracting arteries, increasing blood pressure, and is causing release of aldosterone, which is causing fluid retention. So all this stuff is kind of decompensating because you're causing the heart to have more work when it's already not working properly. So chronic stimulation, sympathetic nervous stimulation, and decreased renal perfusion increases renin release. And so we're going to inhibit angiotensin converting enzyme and block this. This looks like all, because of my font, it should be A2 blockers. Let me just do that because it's a sans serif font, if you know what that is. So you can't really tell that those are I's, they look like L's. Okay, A2 blockers. So one or the other or both, we're going to block the effect of angiotensin 2. Now, this is not necessarily true for the elderly or the African Americans, and no one knows why this is true for African Americans, but it's the way it is. They tend to be resistant to treatment with ACE inhibitors, which means that ACE inhibitors don't have an effect. So their problem is not renin. So they have hypertension. HTN is hypertension with a low renin. So you have to do something else. And one of the things they do is hydrazine with a long-acting nitrate. So hydralazine, if you remember from our hypertension lecture, is a direct vasorelaxer. And nitrates, as you remember, are more venous relaxers. So you're decreasing preload and afterload with hydrazine and isosorbide dinitrate. Again, I put this talk together yesterday, and I didn't go through it once before I gave it. So, so there you go. When I first started, let me tell you this story because we've got time to kill, I believe. When I first started teaching in '94, I would put a lecture. The way I put a lecture together was I'd write out my notes, and I would practice the notes about 3 or 4 times before lecture. And then I'd go to lecture and put the notes in front of me, and I would read the note, read a line from the notes, say it out loud, write it down. Read a line from the notes, say it out loud, write it down. Now it's like, throw it together the day before and just kind of BS. It gets, the more presentations you do, the easier it gets. Okay, but that's neither here nor there. Aldosterone inhibitors. So also, with the renal decrease in renal perfusion, you're going to release aldosterone both through the angiotensin mechanism and just directly because I guess that's not renal perfusion, it's more hypothalamic because your blood pressure is reduced. Your hypothalamus is going to release more ACTH or something, and that causes more aldosterone release. So we're gonna block that as well, and that's going to decrease your blood volume by decreasing sodium retention. Beta blockers. Beta blockers are always fun. No, but with your overstimulation of the heart, one of the things we said was tachycardia, right? You're stimulating the heart to beat stronger and faster. The stronger isn't really working, but the faster is still going. So you keep stimulating it, like stimulating. It's going faster and faster. Now you've got tachycardia. Your heart rate might be 120 beats a minute at rest. That's not good. So beta blockers will bring that back down and also kind of protect that ventricle from the overstimulation. One of the molecular things we talked about just a couple minutes ago was how overstimulating the ventricle increases cyclic AMP, and then you get hyperphosphorylation of their iodine receptor. And so overstimulating that ventricle is not good. So this is going to protect the heart from that happening. Neprilysin. Now this is something we haven't talked about before because I just learned it from Dr. Gogo. So neprilysin, and he just throws it, neprilysin inhibitors, blah, 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 blah. So I'm like, okay, yeah, Wikipedia. So neprilysin is an enzyme, and it breaks down a lot of different things, and it's involved in a lot of processes. But one of the things it does is break down atrial natriuretic factor. So again, go back to your hypertension lecture, and you'll see that I talked about ANF. So when the atria get stretched a lot, when they get extra stretch, they release ANF, and ANF causes a sodium loss to bring your pressure back down. So neprilysin then will break down ANF, so it stops the effect of ANF. So the neprilysin inhibitor then will increase ANF, which increases your body's normal ability to lose sodium and decrease blood volume. So neprilysin inhibitors are big now too. And that's always like a good kind of drug in that it's not like, we'll talk in a minute about digitalis and how it blocks the sodium potassium ATPase, but that enzyme's everywhere and it does so many things. So you block that to help the heart, you're going to get side effects everywhere. This is an enzyme that is doing this and you're blocking that. And well, your side effect profile is low. So if it's going to help, why not throw it in there? So here's a drug I throw out because I see this used to see this on television a lot when I would go visit my dad. See, I don't watch television in Vermont. We cut the cord years ago, so we just watch Netflix or whatever. But when I'd go visit him, we're watching regular network television and old person television. So you're constantly getting hit with drug commercials. And this is one I would hear all the time, Entresto. So Entresto is a combination of an ACE inhibitor and the neprilysin inhibitor. So this is your ACE inhibitor and this is the neprilysin inhibitor. So combination therapy there is, now you're taking one pill instead of two, basically. Diuretics. Diuretics are also big in congestive heart failure because it's going to decrease your blood volume. Again, you've got edema everywhere because your blood pressure is high and your blood volume is high. So fluid loss decreases in hypertension and edema. Fluid loss. So the diuretics cause fluid loss, which decreases hypertension and edema. Let me make that more clear. Bum, 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 bum. Bum, 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 bum. Again, you're seeing behind this curtain here. Fluid loss decreases your hypertension, which is one of the problems, and also decreases edema. The kind of first line one is usually furosemide, which is a loop diuretic. It's a really strong diuretic, so you lose a lot of fluid. Thiazides are other diuretics, chlorothiazide, chlorohydrothiazide or something. We talked about that. in our hypertension lecture. So these decrease fluid pretty well. Spirolactone is probably better. This is going to be potassium sparing, which, these are not. Here you're losing sodium. You're losing sodium and potassium with these, and low potassium is a problem because it will cause cardiac arrhythmia. And if you're in heart failure, your heart's already beating really fast. You're close to an arrhythmia. So if you lose potassium, it could cause a lot of problems. So typically spirolactone is a better diuretic for this. Vasopressin, we talked about that as part of the, causing fluid retention at the collecting duct. So your vasopressin antagonist conivaptan is going to increase your fluid loss there. Positive inotropic agents. Now, see, when I was in graduate school in the late 80s, mid to late 80s, this was the big thing everyone was looking for. The problem with cardiac output is the problem with heart failure is that the heart's not contracting strong enough. Let's make it contract stronger. Only makes sense, right? And the classic thing at the time was digitalis. We'll talk about that in a second. But basically, you want to make those ventricles contract harder and increase cardiac output because that's your problem. Your cardiac output is low. But clinically, these things have not been proved to work long term. Okay, they can in short term increase your cardiac function, but long term, it's not increase. It's not giving you good outcomes, as they say. And so Perky says, used for end-stage heart failure as kind of a last-ditch effort to keep them alive a few more days or something. Because, when you're making the ventricle contract harder, you're getting more cardiac output, but now the ventricle is working harder. And, if your problem, if you contract harder, you're using more ATP, which means you need more oxygen. So if your problem is coronary artery disease, you're just going to exacerbate the problem. Your heart's going to you're going to have more cell death and weaken that muscle further. So this isn't something that's really considered good therapy at this point. So digitalis. When I was in grad school, they told us digitalis is the gold standard of care for congestive heart failure because digitalis increases cardiac output. And it does really well. It does a great job of increasing cardiac output. And it does that because it blocks the sodium potassium ATPase. And by blocking NKA, you increase the sodium inside the cell. So that slows down your sodium calcium exchanger. So if you remember, your sodium calcium exchanger extrudes calcium with sodium coming in, right? You're exchanging 1 calcium for 2 sodium, I believe. So if you decrease the sodium coming in because there's more sodium inside, right? Decreasing that driving force for sodium to come in, you're decreasing the calcium relief extrusion as well. So there's more calcium around. The SR loads more calcium into it, and so you've got more activator calcium and a stronger contraction. So it does increase that cardiac output. But again, you're giving the ventricle more work to do, and that's the problem to begin with. Dobutamine then is a beta-1 selective agonist, so you can stimulate the heart some more, but like we said, the problem is it's overstimulated. You've got too much cyclic AMP already. Hit it with some dobutamine, it's going to contract stronger, but it's not a long-term thing. It's not going to help in the long term. So positive inotropic agents were a good idea, but they don't really work. Oh, and that's it. And that's what we have for today. Okay, so let's look at what the Perkster has to say. Actually, that's what his Comcast email address is, perkster@comcast.com. You can see my to-do list there if you want to. Oh, is this it? No, this is not it. All right, maybe I closed that window. Hang on 1 second, people. Yeah, I did. Let me open that again. So, where are we? So I'm really psyched that we had Perky come in and talk to us because he really knows his stuff. It was fun to listen to him talk, and I really enjoy this explanation here because he does a really good job. So the main question I asked him here was, what about positive inotropic agents? I have to get this to the point where I can actually get around here. Okay, so, damn it. A few drugs increase cardiac output, but we only use them for end-stage heart failure when they are hospitalized with an exacerbation of their congestive heart failure. These would include milrinone and dobutamine. So milrinone is a PDE inhibitor, a phosphodiesterase inhibitor. So this is going to increase cyclic AMP directly, indirectly, I guess, I don't know, but increase cyclic AMP in the heart. And dobutamine, which is a beta-1 agonist. See, they don't even use digitalis anymore. It's very toxic too, by the way. You can imagine, sodium potassium ATPase is everywhere. So if you're blocking it in the heart, you're blocking it elsewhere as well. And also, it can cause arrhythmias in the heart. It's classic for causing arrhythmias. So that causes sudden death. So it's a very dangerous drug. These would be, they do not improve long-term outcomes, but just get the patients out of a jam. So they've decompensated and they're in big trouble, get them back up to normal, and then stop using the treatment. The real drugs we use for congestive heart failure over the long term really decrease the burden put on the already failing heart through pre and afterload reduction. Boy, doesn't that sound like a good question for an exam. The analogy would be to stop flogging the tired horse and just unload the wagon. Digoxin has fallen out of failure for cardiac congestive heart failure because large randomized clinical studies show that it does not improve outcomes such as mortality or CHF hospitalizations. Some studies show worsened outcomes. The current class of medications approved for CHF all do improve these harder outcomes in RCTs, return cardiac therapies, maybe, I'm not sure. But the drugs, ACE inhibitors, angiotensin receptor blockers, beta blockers, neprilysin inhibitors, aldosterone inhibitors. Digoxin has a mixed history in the treatment of atrial fibrillation, mostly because mortality and hospitalization as outcomes are not really affected by digoxin or any of the other medications we would use for controlling heart rate. Betas and channels. Oral anticoagulants significantly affect mortality in the high-risk atrial fibrillation population. So that's another thing we didn't talk about, but it's really important. For some reason, I don't understand why, but atrial fibrillation, fibrillation means unregulated heart rate. So the atria are just kind of like jelly. They're sitting there jiggling. And for some reason, that causes strokes. It must cause clots to form somehow. I don't really understand why. Maybe blood is pooling in the atria and forming clots there. I don't really know. But it causes stroke. So they would at one time use digoxin to stop that fibrillation, but instead they're using your anticoagulants. Beta blockers are associated with decrease in exercise tolerance, but only at the high end. High-end exercising means. They don't impair moderate exercise. This doesn't impair the quality of life for elderly patients much because they're not exercising, but I use them sparingly in active younger patients. Beta blockers have also fallen out of favor for treatment of stable coronary artery disease and as a first-line antihypertensive. So again, for that same reason, you're decreasing the ability to exercise, which is decreasing quality of life. So if you've got other drugs that are better, you go with those. In terms of the consequences of uncontrolled hypertension, the majority of CHF due to hypertension is diastolic congestive heart failure. So heart failure with preserved ejection fraction. That's the thickened wall hypertrophic heart failure. However, we still see cases of CHF okay, which is the reduced fraction due to severe uncontrolled hypertension. So no one's sure what predicts whether you're going to go to preserved or reduced, but some suggest smoldering moderate hypertension is responsible for the former and severe for the latter. So what he's saying is that if you've got moderately high blood pressure, that's going to cause hypertrophy and diastolic heart failure. If you've got severe hypertension, that can cause your dilated cardiac myopathy, the congestive heart failure. Progressive aortic insufficiency tends to be left-sided valvular. All right, let's not worry about this. This isn't that important. But it is interesting, but it's not necessarily what we were talking about. Okay, people, that's what I have for today, 10:23. So Dr. Slish being Dr. Slish, he looked at the calendar the other day, and my plan from here out was to have you guys do an exam on Tuesday, and then let's see, do an exam on Tuesday, and then Thursday we would start you guys presenting papers, and then for the next 3 weeks we would present papers, and that would be the semester. But guess what? We don't have 3 weeks. I do this every year. You think I would learn? So anyway, after Tuesday, we've got class Thursday, and then we're into Thanksgiving week, and then we have 2 more days after that for the semester. So, I mean, we don't really have that much time left. So I'm not really sure what I'm going to do with those last 3 lectures. Hopefully, I'm going to figure that out between now and Tuesday. I will have an exam up for you on Tuesday to take. I'll see if I can get a practice exam up for you this weekend. Maybe I'll get that done today. I've got a lot of other work to do, but I'll try and get that up for you because I know that's important. So can I see your faces real quick? Oh God, not yours, Dante. Oh God. Okay. So any questions or comments? No? Okay. Matt, how are you doing?
I'm fine. I'm stuck in the room.
Okay. I'll email you. All right. So, all right, guys, that's all I have for today. And I hope you study a lot before Tuesday because that test is going to be really, really, really hard. I'm going to make this one really hard.
Yeah, I have one question.
Okay.
Are we, instead of doing a final exam, are we going to do like the presentations? Was that the idea?
I don't know what the hell we're going to do, frankly, because we've got 3 days, we got 3 class periods left and then the final. So I'm going to try and figure that out this weekend. I think maybe I'll present some papers for those 3 days and then we'll have the exam on that. I guess that would be the best way out, but I'm not sure yet. Okay. All right, guys. Thank you so much for coming. I hope to see you again. Bye-bye.